Now we are going to start about the vaccination. The vaccination is the process of administering a vaccine to help the body develop immunity to a disease. The vaccine contains weakened or inactive parts of particular disease-causing organism that triggers an immune response, teaching the body to recognize and fight off the disease if encountered later. This is a crucial process in the public health measures that have significantly reduced the prevalence of many infectious diseases. The vaccines can be having the B and T cell response without overt infection, and they make the protection via immune memory. Immune memory. And having the various type life attenuated, cared, aura, muscular. So first we are going with the live attenuated vaccine having the pathogen modified to be less virulent. So we'll start from here. In the description, the microorganism render non-pathogenic but retains capacity for transient growth within the inoculated host. The microorganism render non-pathogenic. The pathogen you are injecting, it is become non-pathogenic due to some modification. And certain live vaccines are MMR, measles, rubella, varicella, and may be given to people living with HIV who have a CD4 cell count greater than 200. In consultation with the specialist in infection disease or immunology. Basically, we are not giving the live attenuated vaccine to the immunocompromised patients like in HIV or AIDS because they're having some risk of infection. But if a HIV patient having the CD4 cell count greater than 200, then we can get live attenuated vaccine. In the supervisor specialist of infection disease department. What is the pros and cons? The pros are induce several and hormonal responses, like they are doing cell-mediated response. And they induce a strong, often lifelong immunity. And what is the contraindication may revert to virulent form. Sometimes the live mistakenly the microorganism did not render not pathogenic qualities and they become more pathogen to the organism or human being, and if given to less than 1 year, the maternal antibody may kill pathogens and contraindicating the pregnancy in the patient with immunodeficiency because in that patient there is risk of infection by these vaccinations. We are having the examples, and for that we are having a mnemonic that the attention teachers, please vaccinate small beautiful young infants with MMR routinely on daily basis. For the A, we are having adenovirus. For the T, we are having typhoid, P, polio, then vaccinate varicella, smallpox, small, beautiful BCG, young infants, yellow fever, infants, influenza, and then MMR, mumps and measles, rubella, and routinely means rotavirus. Don't forget this mnemonic. Attention teachers, please vaccinate small, beautiful young infants with MMR routinely. And what are some adenovirus, typhoid, polio, varicella, smallpox, BCG, yellow fever, influenza with MMR and rotavirus? Understand? So we are going to kill on inactivated vaccine. The pathogens is inactivated by the heat or chemicals. Maintaining the epitope structure on surface antigen is important for the immune response, mainly induce a hormonal immunity. If you guys remember the structure of antibody, there was one diagram. It's like this. There were antigen binding, and here there was one structure was binding in the diagram, and they mentioned epitope. The epitope is a structure for the recognition of the microorganism that were present, and they mostly use for all the things to recognize a microorganism. That is the epitope. So What are the pros? What are the pros and the contraindication? It's having the benefits safer than live vaccines. It will less side effects and they're having the strong hormonal immunity. Hormonal response is strong hormonal response as compared to live attenuated, and they're having the weaker immune response than live attenuated and no risk of infection. It's also a good thing they have no risk because already the microorganisms are killed inside the vaccine. And contraindication because they are the weaker cell-mediated immune response and live attenuated may induce a hormonal response that boosters or shots usually needed. And many are giving booster shots. After vaccinate, many of them are getting booster doses. And what is example? A trip could kill you. It's a mnemonic. A trip can kill you. Hepatitis A, typhoid, rabies, influenza, and the polio sac. And one thing more, guys, if you notice, typhoid is also life attenuated and killed inactivated. If the typhoid is given orally, then it will be life attenuated. If it's given intramuscularly, then it is, remember, then it is inactivated or killed vaccine. Okay. Now we are going to watch nitric polysaccharide and conjugates. Overuse specific antigens that will stimulate immune responses, immune system. If you guys know, there was in we have an antigen presenting cells, they always took one of a stimulating thing that recognizes the pathogen like LPS, polysaccharides, mannose, etc. So these type of things we're using for the vaccinate when injected deed like mannose or polysaccharides who are giving that type of proteins into toxin that given then already that antigen presenting mediate the immune system and it what gets vaccine. They are having a target specific epitopes of antigen and lower chance of adverse reaction. And what is a contraindicated? It's a many expensive and having the weaker immune response. And basically, we are using them for the hepatitis B virus, human papilloma virus, acellular pertussis, Neisseria meningitidis, Streptococcus pneumonia. Also, they are having the T-cell independent responses. If you guys remember, they are having T-cell independent responses and they having a PCV15 and PCV20. By the PCV, the pneumococcal conjugate vaccine. Theta, pneumococcal conjugate vaccine. Having a polysaccharide produce T-cell independent response, having HPA helper shots. We talk about the toxoid. In the toxoid, there is a denatured bacteria toxin with an intact receptors binding SARS and they stimulate the immune system to make antibodies without potential of causing diseases. They just go and bind with the antibodies and give the response and they did not cause any disease. They protect against the bacteria toxins. They have a different toxin, endotoxins and etc. They haven't got their antitoxin level decrease with the time the booster dose is needed. In toxoid, we have to need booster dose. Like we are giving in killed or inactivated vaccines. And what are toxoid we are using for the Clostridium tetani, Corynebacterium diphtheria. Okay. mRNA for the mRNA are lipid nanoparticle flavors mRNA causing cell to synthesize the foreign proteins like spike proteins and SARS-CoV-2. So that we are using and what is SARS-CoV-2? As this is the example of mRNA. This is rare, acute, respiratory, the severe acute respiratory syndrome. What about the COVID? That is a corona virus 2. And it's a strain of a coronavirus that causes COVID 19, the respiratory illness responsible for the COVID 19 pandemic. That was mRNA vaccine. And what has happened? There's a high efficacy, induced several and hormonal antibodies, and they are saving pregnancy. And contraindication, they are local and transient systematic fatigue, headache, and melancholia, and reactions are common. And they are having the rare myocarditis, pericarditis, particularly in young males. These are about vaccination. But if you guys know, they have different routes. There is the oral and intramuscular. In the oral vaccines, if you guys know, in oral, they are going to stimulate GI mucosal immunity, and they are largely IgA responses. And for example, they are going oral poliovirus and otavirus. And if you are going IM intramuscular, then they will stimulate the tissue response. They are going for tissue response, and they are having large IgG. Okay, but if you are going any vaccine oral, then it will give largely IgA response. If you're giving any vaccine intramuscularly, then it will go IgG response. Understand? And most of vaccines are giving passive immunization. They are giving passive immunization because with administration of antibodies, and they are having the short-term protection in the weeks, no mammalian long-term protection used for dangerous immunity infection like rabies, tetanus, also maternal antibodies like fetus, and sometimes passive and active done simultaneously like rabies, immune dropping plus rapid vaccine. Understand? This is all about vaccination. Now we are going to start about the hypersensitivity types. Hypersensitivity type is the immune responses that causes this. Yeah, immune responses that cause diseases, and they are exaggerated or inappropriate. They are exaggerated and inappropriate, and they can be allergic reactions, like that is a subtype of hypersensitivity. And if we talk about the hypersensitivity, is what is going to happen with the first contact with antigen. First, the body will contact with the antigen, and it will sensitize. They will sensitize the immune response, and there will be generation of immune response by the antibody and the memory cell. But when that same antigen comes second time, then they will, the second time contact will go with hypersensitivity. Phenomena just like that. And the symptom from overreaction of immune system, and there is a four pattern of underlying immune response in the type 1, 2, 3, and 4. There are four types: anaphylactic and atopic type 1, antibody-mediated type 2, immune complexes type 3, and cell-mediated type 4. First, we are going to talk about type 1. The type 1 is an immediate reaction to antigen, and it is in a minutes, and it can be happen by the pollen, pet, dendropinus, and they have a preformed IgE antibody that's a primary exposure. They're having preformed IgE antibodies that due to the primary exposure, the antibody bound to the mast cells, and these mast cells go into antigen bind and cross-links IgE and a mast cell degranulation. And they with suspectable intervene make IgE to antigens, and majority of people take IgG. IgG does not trigger the hypersensitivity response, but the IgE results from B cell class switching or driven from. Basically, what is going to happen? IgE, and it is converted to IgE by the class switching, and that is driven by hormonal response, and this is response required by T helper 2 cells. Helper cell 2, who is doing is scalp switching helper cell 2, and IFF interleukin 4 is a key cytokine for IgE production. It is a key cytokine for the IgE production. And guys, there is a no complement. IgE does not activate by the complement system, as you guys know. In the type 1 symptoms, if we will talk about the type 1 symptoms, then there will be skin, urticaria, hives. It could be respiratory tract infections like rhinitis, inflammation, wheezing or asthma. And secondly, there's the eyes, conjunctivitis or diarrhea, etc. There could be anaphylaxis reaction like systematic type 1 hypersensitivity reactions, anaphylactic panic. They're having the itchy, diffuse hives, erythema, and the respiratory distress from the bronchoconstriction. And they're having the hoarseness, laryngeal swelling, edema, vomiting, cramps, diarrhea, shock, and death, and a treatment in epinephrine. And also there is atopy. Atopy means there is a genetic predisposition to the localized hypersensitivity. And they have the urticaria, rhinitis, asthma, and usually positive family history for similar reactions. And if you guys having the examples of a type 1, there will be asthma. There will be asthma, penicillin drug allergy, seasonal allergy, allergic rhinitis, allergic conjunctivitis, peanut allergy by the children, and fish like food allergy. And if you talk about the type 1 early symptom, it occurs within minutes. The symptoms are going to occur within minutes. By the degranulation of the mast cell, and they will going to release preformed mediators like histamine, and they will synthesize the release of leukotriene and prostaglandins and edema, redness, and itching. And the late symptoms are 6 hours later. And it is due to release of synthesis of cytokines. They are having the influx of inflammatory cells like neutrophils and eosinophils. And secondly, it having the interaction. And if we talk about the type 1 mediated, and most common mediator is histamine. The histamine is the most common mediator, and they will cause a vasodilation, due to which you will form on that side, and it will increase the permeability of venules. That will cause swelling. The swelling is due to increasing permeability of venules, and they are also having smooth muscle contraction that results in bronchospasm. That are main functions of histamine in the hypersensitivity 1 reaction. It will go and do vasodilation, increase in permeability of venules, and smooth muscle contraction that will result in bronchospasm. They are also having leukotrienes, prostaglandin, and thromboxane that are all derived from electronic acid. What? The leukotrienes, prostaglandins, and thromboxane. These all are going to be mediator of type 1. If you're going towards eicosanoids Just like that. Like this is a lipid cell membrane, and it was going to make arachidonic acid by the help of phospholipase A2. Okay, that arachidonic will convert into nicotrans. One day we convert into thromboxane or prostaglandins. Arachidonic acid is going to convert into nicotrans by the help of lipoxygenase, and arachidonic acid thromboxane or prostaglandin by the help of cyclooxygenase. Cyclooxygenase. This is the aqueous nodes, and if we make the sample of a table of type 1 mediators like that we are doing, and we are making a table like prostaglandin E2, prostaglandin E2, prostaglandin D2, LTC4, and LTCD, and LTB4. Nicotrans C4, D4, and B4. What do you guys know? The prostaglandin going to do redness by the vasodilation, edema by increasing the permeability, and also fever by the acting on the hypothalamus, and second pain by the nerves. And prostaglandin D3 will do the bronchoconstriction, eosinophilic infiltration, and nicotrans are going to do vasodilation and bronchoconstriction. And also the nicotran B4 is going to do neutrophil and eosinophil chemotaxis. That are mediators and their effect. We also having other mediators. Other mediators are ECFA, like eosinophil chemotactic factor of anaphylaxis. Eosinophil chemotactic factor of anaphylaxis. They preformed in mast cells and they attract the eosinophils or the various stores. Also, we having the serotonin. They preformed in the mast cells and caused vasodilation. We're having the platelet activating factor and also doing bronchoconstriction. Also, we're having a neutral proteases. Neutral proteases like the chymase, tryptase. Also, we're having the heparin. They're the anticoagulant. These are other type 1 mediators. For testing for the type 1, testing for IgE, we will going to do puncture of skin or pinprick or puncture of skin, that will be also intradermal injection, transdermal injection, and if there will be a positive response, and there will be wheal formation. For example, this is the skin, but if it having a positive vacuum IgE, it will be like that. A wheal were formed on the skin. Understand? And for desensitization, what we are going to do? Would this gradual administration of increasing amount of allergen or response change into? So desensitization, you also do like that. For desensitization, we gradually do the administration of allergen by increasing the amount, and the response is going to change from IgE to IgG, so that the body becomes desensitized, and IgG antibody can block the mediator release and modify the T helper cell too. Let's start from the book, the type 1 hypersensitivity. Type 1 hypersensitivity is anaphylactic and atopic. They are having two phases: immediate, intermediate, and late in the hours. Intermediates due to antigen crossing the preformed IgE on the pre-synthesized mast cells. They will go for immediate degranulation and release of histamine. And do a vasoactive amine and test mark of the mast cell activation and leukotrienes. For the late hours, the reaction we're getting over sometimes that will by the chemokines that track the inflammatory cell and eosinophils due to cytokines. And other mediators from the mast cells, inflammation and tissue damage will be there. There will be two types, two phases, the immediate and late. The first type is the fast and anaphylactic. The first is a very fast, and for the test we will use a skin test by giving some intradermal injection, and which will be positive response and reformation is there. For blood cell, for the ELISA, for the allergen specific IgE, and the example are anaphylaxis reaction, allergic asthma, like that. So the Razo diagram, they will allergen specific IgE antibody, allergen come and attach with it, and it will going for the Fc receptor for IgE, and they will be decannulation of mast cells. Let's talk about the type 2 hypersensitivity reaction and type 2 hypersensitivity reaction. There will be antibodies. There will be antibodies, and these antibodies like IgG or IgM, and they're directly against tissue antigens. Against the tissue antigens, and they will binding to the normal structures. They are going to bind with normal structures. They are going to bind normal structure, and three mechanisms of tissue cell damage are there by the phagocytosis. There will be complement mediated, like complement mediated lysis, and third we having antibody dependent cytotoxicity. There are three mechanisms for tissue and cell damage by the type 2 hypersensitivity. In phagocytosis, there will be Fc receptor. In phagocytosis, there will be Fc receptors or C3b receptors in phagocytes. In complement, there will be IgM or IgG that you go for the classical complement cascade. Classical complement cascade. Or there will be formation of MAC, and that MAC will go for the cell set. You guys know the complement system going to activate by the three pathways. Take one was spontaneously, that called alternative pathway by the mannose binding lectin, and third was a classical pathway. And third, however, antibody dependent cytotoxicity. They are having the antibody dependent cell-mediated cytotoxic, and they will use the natural killer cells. They will use natural killer cells. That natural killer cells are going to bind with Fc ligand of IgG. So they will active and cause a destruction. For the example of type 2, we having the rheumatic fever, rheumatic fever, and they're having the strep antibodies that cross-react with the cardiac myocytes. Strep antibodies that is going to cross-react with cardiac myocytes. Then we're having next example, exposure to wrong blood type. And this is to the RBC lysis by circulating IgG. By circulating IgG, and they are having the erythroblastoma fetalis. If you guys know that, yes. Fetalis. And second is the autoimmune hemolytic anemia. Hemolytic anemia. And due to many of drugs like methyl-dopa and penicillin. As penicillin. And second, D drug bind to the surface of RBC and cause the damage and destruction of RBC by the system, and there is a mycoplasma pneumonia. Mycoplasma pneumonia. And that will also induce RBC antibodies. Further, we are also having some examples. That examples includes pemphigus vulgaris, pemphigus vulgaris. Mean there will be the antibody against the desmosomes in epidermis. Desmosomes in epidermis. And second, we have an example of good posture syndrome. In good posture syndrome, we are having nephritic. We are having nephritic syndrome and pulmonary hemorrhage. The good posture syndrome includes nephrotic syndrome, pulmonary hemorrhage, and having the type 4 collagen. Yeah, also having type 4 collagen antibodies. Also, this example includes myasthenia gravis. There will be antibodies against acetylcholine receptors. These are some type 2 hypersensitivity examples, that is antibody mediated, or that is antibody mediated. Let's read from here. The antibodies bind to the surface of the antigens like several matrices. It causes several destruction. Cellular destruction, the cell is opsonized, coated by the antibody, leading to their phagocytosis or complement system active or natural killer killing by the antibody-dependent cell cytotoxicity, which immunoglobulin involved for activity of natural killer IgG. Inflammation, there is a binding of antibodies to cell surface, and there will activate after this there will be activation of complement system and Fc receptor mediated inflammation. For the cellular dysfunction, the antibody bind to cell surface receptors that are going to make abnormal blockage or activation of downstream process. For that, we are also doing the direct COM test that will detect the antibody attached directly to the RBC surface, because in the, already we give one example of autoimmune hemolytic anemia. So in direct COM test, we can detect there is an antibody against RBC surface or not. In direct COM test, they detect the presence of unbounded antibodies in the serum. If the antibodies are attached to the RBC surface, then it will be direct COM test. If they are unbound antibody in the same, then it will be indirect comp test. And they are having the example already done, the autoimmune hemolytic anemia. Mostly it included drug-induced with drug methyl and penicillin, immune thrombocytopenia, transfusion reactions, and they are also hemolytic disease of newborn. Some examples also with Pasteur syndrome that includes nephrotic syndrome, pulmonary hemorrhage, having a type 4 collagen antibodies, rheumatic fever, the step antibody crossing with cardiac myocytes, hyperacute transplant rejection also in type 2 hypersensitivity. Examples are myasthenia gravis. There will be antibodies against acetylcholinase receptor, Graves' disease, and pemphigus vulgaris, in which there is antibody against desmosomycin epidermis. We will talk about type 3. If you're going to talk about type 3 hypersensitivity reaction, then they are antigen antibody complexes. Antigen plus antibody complex will formed and they will deposit in different structures and they will activate complement. They will going to activate the complement system and that cause the cell destruction. Generalized there will be serum sickness and localized. Generalized there is serum sickness. If we talk about the localized, and it will be artist reaction. When we talk about the generalized type 3 about the serum sickness, there will be immune complexes in the plasma. I talk about the serum sickness or generalized type 3, then there will be immune complexes in plasma and they will cause a systemic diseases. And there is usually due to the IgG or IgM that are complement activated and they deposit in various tissues like skin, kidneys, and joints. And they will be going to trigger the immune response into the activation of complement and activation of macrophages and neutrophils by the Fc receptor. And also is having the historical description like a host plasma used for the passive immunization. And inevitable 5 to 10 days later, there will be a triad of the fever, rash, and atretia. To do the antibodies or host serum antigens that are going to deposit in the skin and joints. What was happened in the previous time? They were given a history of passive immunization. What is passive immunization? We are giving a pre-formed antibody to a human being. There were 1% taken host antibodies. After some days, he is giving after 5 to 10 days symptoms of fever, rash, or fracture, itch and the pain of joint. And is it due to happen? Because that antibodies of the serum going to join with the serum antigens and they will going to deposit in skin and joint. And they having like urticaria, purpura, low serum complement levels, low level of complement in the body. Because all the complement going to active and start depositing. There will be purpura, elevated sedimentation rate, there is diffuse lymphadenopathy, lymphadenopathy, there is acute glomerulonephritis. And the toxin seems sickness, the rabies or tetanus antitoxin, and they can be caused by rarely by the penicillin. The same sickness is going to be capsically by rabies. Tetanus antitoxin, also by rarely by the penicillin. Drug as the haptin and monoclonal antibodies. Monoclonal antibodies like tetuximab and infliximab. Another type 3 diseases are post-streptococcal decrumenophractis, systematic lupus, or there's a polyarthritis nodosa. And if we talk about the localized arthus reaction, it's a local tissue reaction usually in the skin due to injection of an antigen. The preformed antibody in the plasma and tissue, they form immune complexes. And that local immune complex forms 4 to 10 hours after the reaction, and they will contrast with the type 1 in minutes. Like it seems like that you are giving the antigen and they will be forming the immune complexes. But you can differentiate the type 3 with the type 1 if it's the localized type 3 by the time. The type 1 is giving the action within minutes, but arthus is giving action after the 4 to 10 hours. And they are having the complement activation and edema and necrosis. If you are doing the immunofluorescence training, there will be antibodies complementing reservoirs. And they will be reported with skin injections like tetanus, diphtheria, hepatitis B vaccine, and insulin. And there will be swelling, redness at site hours after the injection. If you guys know about the hypersensitivity, pneumonitis, it is also called the farmer's lung. Farmer's lungs. And they are due to hypersensitivity reaction to environmental antigens. Now we are going to study from the book the part of type 3 antigens. For this, the immune complex antigen body, mostly IgG, and complexes activate a complement which attracts a neutrophil. Neutrophil releases ribosomal enzymes and can be associated with vasculitis and systematic manifestation. Already they given the same sickness and arthus. The same sickness is systemic. This is the localized. In seems in the prototypic immune complexes, the antibodies of the foreign protein are produced in the 1 to 2 weeks later. Antibody antigen complexes form and deposit in the tissues that the complement activations, and they cause the inflammation, tissue damage, in which there will be decrease in serum complement because all the complement are going to activate and making complex, and they are going to deposit. And for the arthus reaction occur local subacute immune complex mediated hypersensitivity reaction. It's an intradermal injection of antigen into the pre-sensitized and circulating IgG, and individual lead to immune complex formation in the skin. It is due to giving the vaccination or skin injection like tetanus, diphtheria, hepatitis B vaccine, insulin. And if you guys notice, on the same site of the injection, after giving injection, there will be swelling or redness. And this is happen to the enhanced local reaction to booster vaccination. And they are characterized by the edema, febrile necrosis, and activation complement. In type 3 reaction, imagine an immune complex as a three things stuck together: antigen, antibody, and complement. Don't forget, this is a good mnemonic. In type 3, there will three things going to stick together, and they are doing nothing, just going to deposit in different surfaces of the body, that is antigen, antibody, and complement. We are having the example of SLE, reactive arthritis, polyarthritis nodosa, post-streptococcal glomerulonephritis, and IgE colitis. Fever, urticaria, arthralgia, proteinuria, lymphadenopathy occur 1 to 2 weeks after antigen exposure. And CM sickness like reactions are associated with some drugs may act as a hapten like penicillin and monoclonal antibodies. On ready we guys discuss like rituximab or infliximab. And it's also due to some infection like hepatitis B. Also, they did not mention about the antitoxins of tetanus and rabies. Now we are going to talk about type 4. The type 4 hypersensitivity is a delayed type. Reading the renting, they are delayed side hypersensitivity and they have a cell-mediated reaction. Having the cell-mediated reaction. Is a no antibody different from 1, 2, 3. Memory T cells initiate and in there is a memory T cells going to initiate the immune response. What is when there is a classical example of PPD test of tuberculosis in which there are tuberculin protein injected into skin like a Mentox test, like tuberculin protein are going to inject into skin and the previously exposed person had the memory T cell and the CD4 T cell recognize the protein. T cell recognize the proteins on antigen presenting cells MSC class 2 and there T helper cell 1 response and by this the T1 helper cell will be activated and then it will be released interferon gamma and it will going to activate macrophages. And after that the interleukin 12 from the macrophages stimulate the helper cell 1 as a response and that will result in the redness in duration to 24 to 72 hours later. It is after injecting of tuberculin 24 to 72 hours later it will be happen and how it is going to happen. The tuberculin is detected by CD4 T cell by the antigen presenting cell MSC class 2. They will give the response to T helper cell 1. They will activate it and they will release interferon gamma. The interferon gamma will activate the macrophages and that activating macrophages will release interleukin 12 and they will stimulate T helper cell 1 responses to more release interferon gamma and by that macrophages become activates. And now they are having an example the immune response to many pathogens like mycobacterium and also fungi and they are having the contact dermatitis like chemical oil attached to skin cells involve CD cells that attack the skin cell, erythema, itching and 12 to 40 days after the exposure. And if you contrast with type 1, also in type 4 example we have a multiple sclerosis in which there is a myelin basic protein. Let's study from here in type 4 hypersensitivity. These are antigen presenting cells that presenting the antigen and sensitize the type 1 cells that release cytokines, raise interferon gamma and activate the macrophages and they will release interleukin 12. There are two mechanisms each involving T cell. Direct T cell cytotoxicity that will happen by CD8 cytotoxic T cell that will kill the targeted cells like we already know about. They will cause the erythema, the itching by the contact dermatitis, the chemical attached to skin cells like oils and etc. And second, the inflammatory reaction, the effector CD4 cells recognize the antigen and release inflammation-inducing cytokine shown on this diagram. Already you guys know. And these responses that not involve antibodies as the antibodies are using in type 1, 2 and 3. The examples are contact dermatitis like poison ivy, nickel allergy, drug reaction with eosinophilia, and systematic symptoms like stress. Dresses name of this, like drug reaction with eosinophilia and systematic symptoms. Graft versus host disease. We also done with that test, PPD for tuber infection with a PAT test for the contact dermatitis, candida skin test for the T-cell immune for kindling. All tests are following the type 4 hypersensitivity rejection. Therefore, these T-cell transport rejection, TB skin or touching. This is a mnemonic to remember as an example of type 4. And fourth is the last. So, they are giving a delayed response. As you guys know, in one you are getting a response within minutes. In second, you're also getting some hours. And three also in 8 to 12 hours or 1 2 weeks, same like that. In type 4, you are getting delayed type after many 2 to 3 days. In 12 to 48 hours after exposure, they are going to start these type of redness, itching, and asthma. This is all about the hypersensitivity.